Welcome. I'm Valerie Bagley, Vice President of Product Development at the Change Companies, and I'm here with Robert Kehoe and Scott Boyles. We've got a really interesting conversation coming around the intersection between criminal justice and addiction treatment and ways that clinicians and treatment providers can best provide services for this group of people. Robert Kehoe has over 20 years developing treatment programs nationally for justice-involved adults. He's done a lot of training and consulting on best practices in treatment for this population. Scott Boyles is the Senior National Training Director at an organization called Train for Change. He comes there with 30 years experience and background in the substance use treatment and behavioral health field. Train for Change provides training and evidence-based practices in modalities like motivational interviewing, ASAM criteria, and their goal is not only to help people learn, but to really apply at a systems level processes that help facilitate change. So those are some of the strengths that these two individuals are bringing to the table, and we're really excited to have both of you here.
Certainly. Glad to be here.
Thank you.
So I think one of the first things that would be important for us to cover in this conversation about providing treatment for justice-involved populations is this idea that there's a lot of constraints around that, right? In terms of silos between prison and the community, or restrictions around how to treat court-mandated populations and the way we incentivize or de-incentivize these folks. So I'd love for you both to speak from the community side as well as the criminal justice side about what those constraints really look like and what are some of the challenges that treatment providers are up against in providing the best possible care. Robert, could you share a little bit from your background about that?
Sure. I think one of the main concerns is by the time they get behind the fence, as we would say, a lot of the times the sobriety, we're talking about prisons, by the way, versus jails or
Sure.
short-term stays. But by the time they get there, a lot of them are sober, or at least we're not dealing with active use, though there is some that goes on, unfortunately, in institutions, it just happens. There's ways that they get around this, they make their own, or, gets imported in. But it's much different than if you're dealing with, out in the community where people have more access to, use or, abuse certain substances. But to your point, by the time they get to us, we have to go through a rigorous system to determine what they qualify for. Different levels of programming, what the diagnostic criteria, if they have a substance use disorder, to what level does that reach? Is it one or many? Or let's say substances aren't actually the main driver, but it's criminal behavior, it's antisocial behavior. And so the one thing that is important to do is correctly identify what we're really trying to treat. Are we dealing with somebody who's antisocial, who uses or engages in antisocial behaviors, who uses substances, or are we dealing with somebody who really struggles with substance abuse and also engages in criminal behavior? So to answer your question, one of the hardest things to do is to really flesh that out and try to figure out what the participant or what the inmate is really, what his or her main issue is. And that's definitely a struggle for providers.
Are there any challenges, just to follow up with that, around individualizing care and treatment for individuals who are behind bars?
Mm-hmm. Well, depending on their diagnosis, how much time they have, and other factors like what might be available at one institution might not be available at another institution. So there are definitely things that can limit what programs somebody can get into. But it's not, certainly depending on your system. It depends on, that's the other thing, it depends on whatever system, we're talking about here. Different states have different budgets, have different priorities. Unfortunately, some places have very little programming, whatsoever. That they, that the only thing we have is X program. Therefore, anybody who even casually meets the criteria or wants treatment is going to go into this program. So that can be a struggle. But it is important to work hard to get them into the right program, I guess is the way I want to put it.
Yeah. And then Scott, on the community side, you've trained a lot of folks who are working with people who maybe just returned from prison or are on pretrial or have been court mandated to access treatment. So what are some of the challenges and constraints that you see in that world?
Well, I think there's some parallel processes to what Robert's talking about as far as understanding needs. And historically, I think a lot of folks that are referred to care somewhat based on the severity of their crime. And sometimes the type of care or the intensity of care or even the length of care is more understood from a criminal justice side as a consequence for a crime versus identifying the specific needs of the person and then determining the most appropriate level of care based on those needs. So frequently providers who are trying to individualize care or individualize service plans based on the person's needs kind of struggle with this tightrope of helping the person served kind of comply, if you will, with whatever legal mandates are in place for care and services, while at the same time, those mandates may not be the best type of care or the appropriate type of care based on the actual clinical needs of the person. So there's kind of this tightrope and this continued and actually pretty profound working relationship that's grown over decades at this point between criminal justice system and behavioral health care, which definitely is getting better along that lines, but there's definitely work to do. And I think as people understand also kind of there's two different roles within those systems too, as far as behavioral health care is about more personal health, and criminal justice system is about public safety, and they have kind of different responsibilities, and there's definitely overlap, but at the same time, it puts some kind of challenging obstacles, and frequently the person who struggles with the obstacles most is the person served.
That's right. Can you maybe both of you could speak a little more to that tension between, being mandated legally to report out certain behaviors and things that are presented, while also trying to build that supportive relationship with the client?
Mm-hmm. I think, if thinking about a client in the community, not incarcerated, who maybe struggles with alcohol and goes to a liquor store, buys a bottle of, some liquor, and takes it home and stares himself in the mirror and looks at it and opens it and smells it and decides, this is not me, I don't want it, and pours it down the drain. In the community, you would see that as a positive thing for treatment. And if you're incarcerated, it's actually a positive thing for treatment. However, if there's a bottle of liquor on the compound, we need to understand how this bottle of liquor got on the compound. And there's a balance of wearing two hats, because if the individual came in and was willing to admit that he went through all these struggles and yet did not, partake, that's such a good thing. That's so rich that you can use so much of that information, and it models for the other people. If you're doing a group type situation, models for the other people that other people are struggling with this. But custody, public safety, which includes the other inmates and staff members, we know that when people drink, they become more violent. They're more likely to assault others. So from the public safety standpoint, even though we're behind the fence, we're struggling with how this alcohol got got into the facility, or if it's Suboxone, or if it's, hooch, which is, prison-made alcohol. That's certainly an issue. So that's one of the challenges that we see.
But on the community side, Scott?
I think on the community side, there's and freedom's probably not the most appropriate word, but as far as the potential consequences of use and how that impacts an institution is much different than someone who's using within the community. Not to say there can't be significant consequences, but I think a lot of the challenges or opportunity is to think about, we're talking about this thing called a therapeutic relationship. And like any relationship, there's boundaries and there's consequences, positive and negative, when boundaries are crossed. So I think as we provide services to people who are criminal justice involved, that understanding those boundaries within the context of our relationship is a really important initial step, and connecting with the person is like, I am obligated to do these certain types of things, and being upfront about that, or transparent, if you will, and we don't need to get away from that, and we don't need to ignore that, but within the context of our relationship, these are the boundaries, and same boundaries you might establish with a family member or a child. It's like, you have a lot of freedom. However, if you run out into the street out looking both ways, you're going to lose your bike for 2 weeks. It's like, so you can trust me that I'm going to, be there to enforce the boundaries, and within that, still have an engaging relationship built on trust, and also honoring the fact that a lot of times the people we serve, especially coming from anywhere, it's like they may not trust us. And I think we're frequently, we mislabel that, and we mislabel it sometimes coming out of court referrals, or people externally mandated, or they're court mandated, and when they behave as if they don't trust us, or don't want to talk to us, or truly just don't really like us, we frequently end up kind of building on those labels and identifying resistant clients, or they're court mandated, so they're behaving in this certain way. And I think we kind of lose sight that a lot of their behaviors are logical, practical, and really appropriate at times, and maybe really related to how they've learned to take care of themselves, survive, and cope. Mm-hmm. And then, of course, we tell them they don't know how to cope either. But and we could do a whole piece on their coping. He just talked about making hooch. Just like show me the middle-aged Harvard grad who knows how to make hooch.
Right. There's innovation there.
Yeah. So coping skills are relative to environment, and we need to sometimes honor the coping skills people bring to the table. Which sometimes, again, gets lost in a series of labels, or we misunderstand people on what got them to come to treatment, and that becomes a label for them. It's kind of like, what got you to the hospital? Well, a car wreck. Well, here's a car wreck person. It's like, no, that's a person with a broken leg and internal bleeding. It's like, what got you to treatment? Well, court mandated. No, that's a guy who has a serious addiction to cocaine and has a bipolar condition. He's a human. He's not a court mandate. And we lose sight of who they are, sometimes based on what got them there, because it's a tough job.
And I think the other thing that just when you talked about trust, maybe the client doesn't trust me, and certainly that would be appropriate. When you go into any relationship, you're going to give up some amount of trust. And if you think about the experience, have you explored enough the experience that this individual has had in past treatment interventions, saying this is not his first time, because most individuals who really struggle with substance abuse, it's time and time again, and they've had all sorts of people from maybe their parents, maybe in school, and they've maybe had just some bad experiences with other times that they've gotten in trouble, and they carry that with them. That their experience is, I've gotten in trouble for substance use, and now I'm going to get in more trouble, and I don't want to tell you anything because it's just going to add to more trouble. So very appropriate. And in fact, you would actually want to be a little bit cautious with somebody who came in for your first meeting and was too open.
Right.
And has revealed things to you that it would take another person 3-4 sessions at least to even broach the subject. And this person's already, all the way down into it. And that's certainly clinically relevant that you would be like, what's going on here? How come, what is the gain of this? Because that's not what we consider in a normal, healthy relationship.
And ironically, we have a label for that person too. So if you're too closed, you're dishonest and guarded. If you're too open, you appear to lack boundaries. Right. So again, we have sometimes you can't win in our system because we inadvertently default to some of these
right.
stereotypes or pigeonhole folks with what I call kind of clinical terminology and lose sight of that person in the process.
And it takes away from building that therapeutic relationship because I'm not seeing you as a human being. I'm seeing you as too open or too guarded or putting all these labels on you before... because the individual shows up, he's hesitant. Well, okay, let's explore that, or let's see where he or she wants to go.
Yeah. And then, of course, we have a system that is perfectly designed to kind of jump in people's lap before we take them to coffee, is the way I describe it. Because they're hesitant, they're guarded, and what do we start asking them? Some of the first questions we ask people is, do you have any STDs? How many partners have you had? What's your sexual preference? Do you wear a condom? Have you shared a needle? Have you violated the law to support your use? Was your dad an alcoholic? Was your mom an alcoholic? Any family history of mental health issues? And then it's like we're surprised when people don't want to answer those questions or when they're a little closed and guarded. And again, not because clinicians don't care and not because they don't have skills, but frequently we have a form we got to fill out. I don't have time to get to know you, Robert. I got to get my paperwork done. It's like you're a case and I don't get measured on getting to know you. I don't get paid to get to know you. I don't get paid to engage you. I get paid to do service plans, diagnosis, and complete paperwork. And I think that's probably parallel in both systems.
I think it certainly can be. It's that thing that before a certain number of days has gone by or a certain number of sessions have gone by, I need to have behavioral, interventions established for you. I mean, even the way it's said, I've got to have behavioral interventions established for you versus it would be good if the client or the inmate came up with some, what does he want to work on? Right. It's that our time versus my time. You're here on my time. Or the opposite of that is, this is your time. What do you want to do to a fault? Where if that person does, okay, well, this is just your time and we're not going to do anything. And, this is the way you want to waste your, fine and dandy. We're not talking about that, but it's just working together to try to come up with some things versus it's day 27, I've got till day 30. I've got to have 3 behavioral interventions done. So I'm going to give you this to do and that to do and that to do, and which fosters resistance or, compliance, which could just be masking the resistance.
Yeah. And if I could come back to something that you talked about earlier is kind of the knowledge of the person served and maybe prior treatment experiences. And back to Valerie's original question is, we have a chronic condition, substance-related disorder. We know it's chronic. It's been chronic for, I think, decades now. It's not like new information, but we've, for decades, designed an acute model of care to treat the chronic condition. And I think part of the problem or part of the challenge is frequently, I think the criminal justice system is trying to address a chronic condition with an acute model. Well, you're required to do this many days of care, or 90 hours outpatient, or complete residential care, and it's almost like the outcome will be you'll be fixed. And this is a chronic thing. And then when people behave as if it's a chronic condition and they might use or those types of things, then it frequently is consequenced or punished. And so understanding the lines between setting boundaries and that there are consequences for your behavior, while at the same time embracing the challenge of treating a chronic condition why it might threaten public safety issues in the process is just a tricky road.
I think that we've established a lot of the constraints, including that the system is often against both the patient and the clinician when working under, I've got to fill out this paperwork. I've got to check all of these boxes. I almost have to give this person a label, as we alluded to earlier. So if I'm a person who entered the field really passionate and with a deep desire to help, working against these constraints and these labels and these systemic issues, what are some things that I might do to individualize my care and really support the best possible outcomes for my clients?
I think, research certainly proves that the therapeutic alliance, the relationship between the client and the counselor, therapist, is the most important thing to, as opposed to like treatment modality or, other things that you can do. It's just, have you established that relationship with your client? What kind of rapport have you built? Do you see them as an individual, with autonomy? That you're working with that individual. That this is their time, our time versus my time. Speaking as a counselor or the clinician, so I think there's many ways to do it, and as Scott pointed out earlier, hitting the person with a 7-page questionnaire about the first time you thought about drugs or your cousin or, the bad experience you've had in all these, things. It's hard to establish rapport when you're just filling out paperwork. Think about it yourself. If you've gone to a medical appointment and the dread, or I'll make it an I statement, I often dread filling out 9 pages of medical history because I want to go in there and I know what I think is going on and I want to talk to the doctor about my knee, but yet I got to remember my family history of cancer, diabetes, blah, 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 this, that, and the other thing. So, it's having that empathy, putting yourself in that person's shoes who's sitting on the other side or sitting in your office or wherever you're having the session. Is an important thing to do, and how are they feeling? That's one way to foster that therapeutic relationship because you're seeing this person as a human being.
When I fill out that paperwork at the medical office, on the 3rd page, I put, I'm from the government and I'm here to audit you. And what I put that in there just to see if they actually read it. And based on my last 15 years of experience doing that, no one has ever said, hey, why did you put that in here? Because I don't think they do read it, which again talks about, do we design paperwork to help people, whether it's in a medical setting or in a behavioral health setting? Who's the paperwork designed for? And most often it's not designed for the online clinician and the person served, which we can't always change tomorrow, unfortunately. But a lot of times people are like, well, I have to do this paperwork. It's like, well, who designed it and why are you doing it? And those are some simple questions as far as about improvement. There's some paperwork we have to do and we have to get it done, and we don't have ability to change it. But what paperwork can we change?
Even if this paperwork is required and your system is set up in such a way that this paperwork is required, how is the process of getting the paperwork completed done? I mean, how do you go through that? Do you slide it over and, just here, I'll give you 10 minutes, and then we'll get at it? Or does it have to be done? Can it be done beforehand maybe, or in some other way, or acknowledge, hey, this is a big packet of paper. Unfortunately, we have to get this done if we want to move ahead. And I know that, you might not understand every question. That's okay. We can work through it later on. Just acknowledging the process that's going on. Because, again, if it's an initial session, that individual is most likely nervous about something. And, by just, doing something like that, you can assuage that anxiety a little bit, or at least acknowledge it.
It's interesting because I think we so often take people by surprise with our paperwork. It's just like, why'd you come to treatment? Well, I came to get my driver's license back. It's like, well, you came to get your driver's license back. What's up? Well, I got 2 DUIs. They said I had to go to treatment to get my driver's license back. And so that's their truth. That's their reality. That's not a lie. That's not like an unmotivated client. That's what the judge told him, and he's repeating what the judge said, which I think is a damn good thing. Mm-hmm. But frequently when they repeat the judge said, it's like, well, you're unmotivated. It's like, no, that's what the judge said, and I'm doing what he said. Why are you telling me I'm unmotivated? I'm doing what the judge said, and you're telling me I'm unmotivated. It's like, and then when they do that, I'm here to get my driver's license back. Then we start asking them whether or not their parents were addicts and alcoholics and when's the last time they smoked weed. And the guy's going like, what the hell? I came to get my driver's license back and you want to know if my dad's an addict or an alcoholic and whether I was abused as a child. I don't understand this. Well, see, now you're being resistant. And again, we kind of lose sight, and our system lose sight. It's like assessment is a process, not an event. We've turned it into an event. I'm going to figure out in 3 hours, I'm going to tell you the level of care. I'm going to develop a treatment plan. I'm going to give you a diagnosis, and we're going to be on our way.
And oftentimes that treatment plan does not change. It remains constant throughout. And that certainly is an issue that, even if you talked on the logistical side of it, where you have to develop a treatment plan, with your client, but if it never changes, if you never go back and even take a look at it, it's just whenever the 30 days is up, bingo, because he hasn't screwed up, he has completed his treatment plan, we move you on and you now get your driver's license back. So what is the role of the treatment plan in this situation if you never refer back to it, if you never go over it with him, if he doesn't know what's on it? I mean, that's just some paperwork the government's doing so I can get my driver's license back.
And which comes back to really some of the original questions is when we're thinking about criminal justice, working effectively with behavioral health care, instead of mandating programs, we really need to work with each other and teach each other that we want to mandate change. And literally, obviously, you can't mandate change or there'd be no crime. But we want to mandate the following and adherence to the plan of care. And then based on progress or lack of progress on the plan of care, the provider would communicate appropriately to whoever the referent is on the criminal justice side. And then we would adjust the plan of care. So instead of instead of sentencing to people to treatment, let's refer them to treatment and then let the plan of care drive the delivery of services rather than sentencing people to a program and then having them either comply or hopefully change within the context of that program.
Right. Because simple compliance is not change. I'm sure you've dealt with individuals who on the surface would seem like the perfect client. Everything you said, there was an appropriate response to, always on time, always showed up, but if you don't know what's going on outside of your session. So is he just BSing you? And some of them are very good at it, let's be frank, and doing what exactly needs to be done in order to get whatever the goal is, maybe in this case, your driver's license back. So how do you explore that? Are you willing to stir the pot with that compliant, individual and kind of challenge them a little bit? Because if it's just going smoothly and there's no issues and whatever, either there's no problem there to begin with, this was just an accidental, once off, or he's shining you on, or she's, just pulling the wool over your eyes, or, whatever metaphor you want to use. And are you willing to challenge that too? Because sometimes our caseloads get so unmanageable in our minds that we're like, oh, this is nice and easy, and there's really no need to get into that. But again, if the person doesn't really have a problem, then why are they adding to your caseload?
Yeah.
And that, how do you deal with that in that system?
The compliance is interesting. It comes up frequently, both as in my prior role as a direct care clinician and supervisor, and a training question comes up frequently. It's like, so, what do I do with the person who's kind of like complying through the program, or just bottom line, some people say, I just think this guy's kind of BSing his way through the program, and it's like, well, what if you made it their program instead of your program? Because they can't comply through their program. But if it's your program and your program's already designed before you ever met the person, they can only comply. That's one of the other things we need to conceptually rethink. We design services before we even met the people we're going to serve. We already know what they need to do to get well and change. It's like we have a crystal ball and we can see into the future. I already know what you need to do. And I deliver the same clinical services to a 17-year-old whose drug use is specifically revolved around methamphetamine. And I redeliver those exact same services to a 49-year-old who's been drinking whiskey 7 days a week. Mm-hmm. And they both have the same length of stay.
Sure.
And then it's like, and if it doesn't work for both of them, again, we blame them. And that's what happens when we end up mandating people to a program for sometimes, again, as if it's an acute condition that's going to be resolved, rather than truly understanding their individualized needs and developing service plans to reflect that they've been very involved in and developing with their provider.
So I want to go back to one of the areas that I think has been touched on in this conversation. You mentioned, Scott, the case of a person who wants their driver's license back, and that's the reason that they're presenting for care. I think an inclination in the treatment community is to say that person's not motivated. How do we reframe our perception of people rather than labeling them as externally, internally motivated and focus instead on the person?
So, Valerie, as soon as you said externally and internally motivated, I almost came out of my chair.
I watched you.
It's frightening. It's like the reason I'm here today is because I'm externally motivated. I need a paycheck. Mm-hmm. And I think I'm doing a pretty damn good job, don't you?
Absolutely.
See, external motivation is not necessarily a bad thing. And externally or internally motivated is just a broad generalization that really doesn't describe the person. And it's always amazing to me. It's like, we'll say, person's externally motivated to comply with probation. And it's like, when I do something to comply with a law, I'm a good American.
Very rational.
Yeah, when the people we serve do something to comply with the law, they're externally motivated and sometimes being manipulative. Mm-hmm. It's like we have this double set of standards that I think sometimes we get lost in. And honoring and not losing, which all comes back to labels. And we talk about decreasing stigma from a societal place, but decreasing stigma within the context of our services, our service delivery, and how those labels impact not only the person served, but how we might engage with them and how we might totally miss what their true individualized issues are, and how we might also inadvertently put up barriers to connecting to that person. And just lose awareness. It's like they're externally motivated, but I think Robert mentioned they've taken, they took public transportation across town. They had to climb off a roof because of their roofing job and tell their boss that they were going to a chiropractor because they didn't want to tell them that they were going to an addiction counselor. They have to use money, maybe their last few bucks on transportation. They have to fill out all this paperwork. They have to get qualify for Medicaid. They have to pee in a cup. They have to sign a release of information so you can give their probation officer information. Right? They sign a release to allow you to give their probation officer information after they pee in a cup. And then we say, man, you seem a little externally motivated. It's like, right. What? Yeah. When's the last time you did all that? Try it tomorrow. It's like, right. That's profound what that person has done.
Regardless of the motivation and the label and the need to label it external, internal, they've done so much to make it. Why would you knock that down in any sort of way? You know what I mean? How about saying, hey, you really did a lot, especially if you know this person did a lot to make it here. Why would you get into he's externally motivated or all he wants is his driver's license? Let's think about it. If for some reason you lost your driver's license because you failed the eye test, let's say, maybe you couldn't read it correctly, you would be pretty motivated to get your driver's license back. And that would be a rational thing to do. So, the bad part would be is if you paid the person giving you the eye test $25 so you could memorize it. We're not talking about that. That's that antisocial, unsafe behavior, But we're talking about, hey, the next time I go, I'm going to make sure I'm going to go to the doctor's, I'm going to get my prescription, make sure it's my appropriate prescription, and then read the eye chart and not kind of half pay attention, and you just get lost in your own things. And so I think this is what's important, that people are saying they're in here for the wrong reason. Before you say they're in here for the wrong reason, let's at least figure out what's going on with them and why they think they're here. And if it's to get their driver's license back or to get some secondary gain, that's not necessarily a bad thing. In fact, it's probably a rational thing. Now, if the only reason they show up is for whatever, some piece of paper, then meaningful change might not happen 3, 4, 5, 6 months down the line. We can take a look at that as you get to know the individual. But they made 3 appointments in a row after all this rigmarole to get to those appointments. Let's celebrate that. Doesn't matter what gets you in the door. Or at least that's what I used to say. It doesn't matter what gets you into treatment. The reason you stay in treatment will eventually evolve, or you will no longer be in treatment.
Do you see this sort of labeling game playing out in the prison settings that you've worked in as well, Robert?
I don't think it's unique to prisons, but it certainly does occur. And I'll be quite honest, I've been guilty of it myself, where it's just easy to say, here's my whatever it is. Here's my narcissist. Here's my conspiracy theorist. Here's my this, that, and the other thing. And you really have to check yourself and pull yourself back and say, wait. This guy has said something that's, definitely a narcissist would say, but why am I labeling him as a narcissist? And even if he met the criteria, he's not a narcissist. He's somebody who has narcissistic personality disorder. So just changing the way you talk about him or her enables you to see them more as a person versus a label or a diagnosis, and you can build that rapport, that therapeutic alliance, however it is.
Yeah, I think we talk about that those terminology. It's like they're narcissists. It's like, well, yeah, and so what?
Now what are you going to do with it?
It's like, well, they're depressed. It's like, well, hell, I'm depressed. So what? What does that tell you about this person? Being a narcissist, you may be very successful in certain lines of work. So that doesn't tell us about what their clinical needs are. That doesn't tell, that's just, which kind of bringing it back to that point, because back to that plan of care, you can't just broadly treat a narcissist or it just has problems, client's depressed, goal, get undepressed. How's that impacting their life? And what's their story behind that, where we ended up labeling them and trying to remind people as, well, when I thought this about this person, what did they do or what did they say that made me think this? And let's go back to that. Because then we start to capture a human. And then we capture it also with words that they said. And sometimes in motivational interviewing, we use these things called reflections, reflecting back as a way to demonstrate empathic listening. And sometimes a great service plan, from my narrow perspective, is really a written reflection of a problem that they've really typically already stated to you. And some of these broader terminologies really sabotage our ability to get in there, to understand those problems, to tailor services, and then measure progress and care based on their individualized needs rather than just kind of going through the program. I also wanted to come back to one of our, as I was talking about this guy who's driven across town and done all these things to get in and see the provider, and then they start treatment, and sometimes the first group we put them in is develop coping skills.
Right.
It's like, what? What? Or it's like the guy coming out of the institution, and it's like put him in. He needs to go to relapse prevention group. It's like, what? He's been in prison for 5 years. I don't know about you, but if I was in prison, I'd do drugs. I would just do drugs. I'm telling you. You know what I'm saying? It's logical. It is logical. It's common sense. If that's, especially where you've come from, that's a great way to protect yourself and feel good when you're vulnerable, sad, hurt, distraught. I mean, drugs are logical. And if I was in prison, I'd do drugs. So we get this guy coming out of prison who didn't do drugs.
Right.
And then we discount that. It's like, well, you need treatment. It's like, maybe I was a peer mentor. And it's like we kind of lose sight that I think that guy should write a book, not go to treatment. How I went through prison without doing drugs. And again, we lose sight based on where people come from and how they show up. We really lose sight of the person based on how they got there versus who they are and what they truly need, or what truly justified the need for care.
So I think we've talked through a lot of really important ways that treatment providers and clinicians can challenge their perceptions, generate more empathy toward the people that they're serving, really see them as human. Are there any other additional concrete skills that you would share with the listeners of this podcast on how they might continue to do that in their practice?
I think skills and or things they might do within the context of their working relationships with their referrals or within their system is continuing to work on and develop partnerships with criminal justice. I mean, criminal justice, let's face it, they've evolved phenomenally in the behavioral health care, and their knowledge base from motivational interviewing to providing direct care services has just evolved. Since I've been in the field, it's, when it went from whatever, we need to punish addiction, and now we're treating it, and apparently they listened. So that's been really cool. So continuing, to build those knowledge bases, and for behavioral health care to continue to educate. Sometimes I think it's like we change the rules and we forget to tell people about it, meaning we've evolved in behavioral health care, and it's like, by the way, criminal justice, we aren't doing it that way anymore. And we don't tell them. I don't know if it's quite that concrete, but I think continuing to let people know, it's like we have this thing called the ASAM criteria. We realize we can't treat everyone at the same length of stay no matter what their needs are. Yeah, we did that for like 3 decades, and we changed. And I think inadvertently, the two systems don't communicate and evolve together. And so, at least from the behavioral health care side, substance abuse treatment, we need to continue to educate criminal justice on what we're doing and why we're doing it so they can support it. And then just the other thing, coming back to assessment, Robert talked about it just a few pieces on that assessment and how we set foundation for a relationship. And he made some key pieces about the assessment process, and then just throwing in, I'm going to ask you some questions that might seem kind of wacky or uncomfortable, and you have a right not to answer those, and be aware, there's things that we need to get through here, and then you have a choice. You don't feel like you have to answer those. And then, darn it, our system has turned assessment into an event. It's like turning like matrimony or dating, it's like turning a marriage into an event. You don't get any courtship. You just have to marry them. It's like our relationship when people shows up. It's almost like shows up for care. We almost like jump right into the relationship. We don't court, and don't take that out of context because it'd be ethical problems for you. But what I'm saying is we need to recognize that this is a process. So how do we design assessments as a process rather than an event, and that we're getting little pieces of information over time as part of an assessment, and also those little pieces of information over time add to that modification, update, revision of that plan of care that you were just talking about.
Right.
Further individualize the care compared to I'm going to figure you all out in 3 hours. I'm going to write a 90-day or a 9-month plan of care, which is, I always tell people, as soon as you wrote it, it's wrong because you didn't figure them out in 3 hours. Yeah. And why did you write a 90-day plan of care while you're telling them to live one day at a time? This is a whole nother thing that confuses me. So again, little itty-bitty steps, and again, what's one little teeny tiny thing we can do to minimize the stress of that assessment? Or what's one little teeny tiny, do we have a relapse track? It's like, how would you like to walk into treatment and say, hey, Valerie, we're going to get you on the relapse track. And then you're going to start the errors in thinking group. It's criminal thinking, Valerie? It's like, what are you telling me?
Yeah. Well, think also, if we're that assessment component, how much different if it would be than, the client walks in and you slide across that big stack of paperwork and start sign here and print there and fill out all these potentially embarrassing or difficult or questions you don't understand. But what if you just sat down with the individual, welcomed them, thanks for being here, thanks for showing up to this appointment, and just kind of talk to them. What's going on in your life, and if you had a 15 or 20 minute conversation with that person, what do you think's going on? How come you're here, or what brought you here, or how's this working for you, or whatever kind of questions you can ask to bring out some of that whatever is going on in his or her life. And then let's say you are required to get through this packet of questions about their history. Well, most likely they've already just told you a whole bunch of these answers. Like, I'm here because it's my second DUI and I've lost my driver's license. And, alcohol really has been a problem for me my entire life. And he goes on in this way. You're going to have this information already ready for your paperwork that you must get done. And as you go through that paperwork, if something was skipped, they don't talk about this, that, or the other thing. By the way, if the individual says, my dad was an alcoholic, I have problems with alcoholic, and I don't even want to talk about my mother, then when you get through that and it says, was your mother an alcoholic, in these, rude questions that are on the paper, you don't even have to address that. He doesn't want to discuss that at this time. That doesn't mean you'll never get back to the point, how did his mother work into his relationships? It's just, this guy, the last thing he wants to do is open up about his mother for whatever reason. You don't know. Maybe she just passed away, or maybe she died in a DUI crash. Maybe she was never there for him. And there's so many things, but with him telling you, I don't even want to talk about my mother, before you asking him, you can avoid saying, now, tell me about your mother, or what about your mother? Was your mother an alcoholic? And da-da-da-da-da, and driving down. And just think how different the relationship will be because you're listening to what he's bringing up. And, maybe he doesn't even bring up the DUI at all. Now what do? He's here because he's had 2 DUIs. And he just totally glosses over it. The system's out to get me and all the, whatever he goes into and, this, that, and the other thing. I really don't want to be here, but I'm going to be here and I'm going to do what I need to do, and just never brings up alcohol. I mean, that's actually, as we used to say, a grist for the clinical mill, that you would expect somebody to say, hey, I'm here because this is my second DUI and I don't have a driver's license. But if he just says, hey, the court's making me do this, and, so you can even get more information versus just, what's on a piece of paper. So start off with a conversation. You have whatever amount of time you have. Spend some of that time just getting to know the individual and seeing what's on their mind. Maybe I'm nervous going to treatment, or maybe hey, this is my 7th time going to treatment. I got it. I know what's on your paper. I can tell you about this, that, and the other thing. And, that person starts asking you questions. How different is that than somebody who's nervous or never been into treatment and, wants to get their license back for that example.
I think a wonderful just additional piece to that fits really well with that is, and if we wanted to attach an MI skill, it would be, elicit, provide, elicit. And a lot of times it's like, what do you know about what we do here? What do you know about my role? And just those little pieces of information can tell us so much, and then also give us an opportunity. It's like, I don't know what you guys do here. It's like, I don't know, I watched Intervention on, TV last night, and I don't know what you do. It's like, help me understand, and being able to ask those questions, and you can think about it in your own lives. You go into back to that. I don't want to pick on medical doctors, and I also don't want to lose sight of the phenomenal, incredible skills that the people we work with truly have. Because so many of them do the stuff we're talking about
right
in such a wonderful, incredible way. But thinking about, like, in your own experiences, you go in the doctor office, this person comes in, they like stick a thing in your ear and they put on a blood pressure cuff and they say, go in the other restroom and you need to leave a urine sample. I don't know why this whole thing's focusing around urine samples, but it's like,
it's a theme.
Before I do all of those things, can you at least tell me who you are? Mm-hmm. It's like, right. Like, who are you? Yeah. I mean, I remember listening to a profound diagnosis for someone, and the provider walked in and didn't even introduce themselves. So, like, what do you do here? Like, I can't tell if you're the doctor or if you're the nurse or if you were just threw on a white coat and walked in, and right. It's like, I'm a little anxious. That makes me anxious. And so some of those basic things that I think we sometimes kind of forget.
I think this has been an incredible discussion between two very talented professionals who've worked with justice-involved individuals in a number of ways over the years. So to summarize, I think a few of the key takeaways that have been covered, we've talked about assessments, right? And learning to view assessments as a process and not an event. Mm-hmm. Starting with a conversation as opposed to paperwork.
I agree.
Letting the plan of care evolve as well as drive services as opposed to specific court mandates. Being individual focused as opposed to merely program focused. Checking your labels, seeing individuals and groups as opposed to how we've been labeling them. And then you gave a nice bonus motivational interviewing skill, Scott, about eliciting and then providing and really making that exchange, a collaboration. I'd love to hear any quick takeaways that you'd like to provide for our listeners to sort of wrap up this conversation.
Well, one thing I would like to say, because you're out there doing this work, it sometimes can almost become cliche or automatic, and it's unfortunate. But it's also that, taking care of yourself, seeing where you are in this situation, you're part of this therapeutic alliance, and making sure you understand that you don't control that person on the other side or, in the session with you. Sometimes clinicians will think they do a good job if somebody doesn't relapse, and they did a bad job if somebody relapsed or returned to use. And to be so cautious of investing too much of yourself into what that person does, outside of your session. I'm not saying you don't have influence, and hopefully you're working together in this therapeutic relationship and positive change will occur, but sometimes it doesn't. And not to take that personally, because that can lead to, not having good thoughts about yourself, not feeling good about yourself, that your abilities are somehow tied up in the outcome of a session, 10 sessions, 15 sessions, whatever it is, when you realize that this person, has done that. So self-care, taking care of yourself, but also realizing that you're part of this relationship, but you didn't cause it. You can't control what that other person is struggling with. I think that's important.
I think just again, coming back to some little things, is how do we convey hope? How do we show the person that we can help them, and hopefully maybe even surprise them and exceed their expectations? What can we do with, even maybe in the context of the physical environment, possibly to even make it more appealing, because maybe we can't change the world tomorrow. And realizing you can't change the world tomorrow, and realizing if you think like that, that's going to give you the first excuse not to do anything. It's because it's too much. So what are those little itty bitty things that you might be able to do? And those are a few. And having that conversation and with the person, assessments process, not an event. We talked about those things. And then realizing that little teeny tiny window of that initial contact may be the only window, or the perfect timing in a very, very small window for that to change that person's life, or to help facilitate the change of that person's life, or be a partner on their new journey. That's a tiny window, and we got to show up at our best not to miss it. It's just so key. And that everyone comes to treatment for the wrong reason. There's no right reason to come to treatment. But people come to treatment because they're court mandated, because they've lost their family. I mean, so the reasons they come, every reason is a great reason. And there's no wrong reason. And coming back to that idea that if they're coming because they're court mandated, like, compared to what? Compared to all the people who show up and saw your commercial last week? There's not another group of people that shows up. Those are the people we serve, people who have suffered and are trying to either make their lives better or avoid consequences, and typically, obviously, a combination of both.
So well said from both of you. And I think these ideas that have been exchanged in this conversation are really valuable for serving any client, justice involved or not. And so thank you for this conversation, and thank you for bringing your expertise to the table.
Absolutely.
Thanks for having us.